I'm going to present on the non-arthroplasty, non-arthrodesis options for the treatment of ankle osteoarthritis, but I just wanted to mention what Dennis Janisse spoke about is really important, to have an orthotist or pedorthist in your clinic and work closely together to treat a lot of these problems non-operatively. So surgery is an option, but non-operative treatment of foot and ankle problems is really essential. And I think if you can communicate and work closely together, you can achieve the goals of the orthotic or pedorthic treatment for these patients. So again, I think we've heard talks, the session 1, and now this session on the various treatments of ankle arthritis. So these are the areas I was going to touch on: arthroscopic treatment, realignment, biologic resurfacing, and just a bit on distraction. And I will not speak on the arthrodesis joint replacement. So we're very familiar that this problem does affect young patients. It's often post-traumatic or repeated traumatic events. It is very disabling, and it's becoming more common and more recognized. And so I think having all the options available for treating this problem is really essential. Again, it's important to understand what contributes to function of the ankle. So understanding the soft tissue anatomy, stability, and the bony congruity is important in kind of determining what needs to be done for these problems. So again, it's important to understand the biomechanics and what is the problem and what is necessary to restore stability, restore alignment, and restore ankle function. So this was an earlier study by Professor Takakura, again showing that abnormal stresses in the ankle joint can concentrate and lead to focal degeneration, chronic overload, and I think understanding this will help you in treatment of these focal problems and even more diffuse problems around the ankle joint. So when you're faced with ankle problems, not just arthritis, but be it an osteochondral defect or chronic ankle instability, tendinopathy, and then ankle arthritis, it's essential to look at the alignment. So you need to assess and correct malalignment with whatever needs to be done in terms of soft tissue or bony realignment. And so here's an example of a middle-aged patient. You can see the varus tilt in the ankle with medial wear of the ankle joint, osteophytes in front of the ankle. And here's the weight-bearing x-ray and the long limb weight-bearing x-ray to assess the limb alignment and the malalignment. Here's a CAT scan, again, to further understand the anatomy and the bony contributors to the arthritis. And so in this particular patient, we decided that we would proceed with kind of realignment surgery and biologic surgery rather than arthrodesis. And so here is the surgery. And you can see we did a fibular osteotomy and a tibial osteotomy to correct the alignment. And then we did some soft tissue resurfacing with biologic stimulation and some biocartilage. And then we did a lateral ligament reconstruction to correct the ankle instability. And you can see the ankle is much better aligned. And the patient is doing fine. You can see it's not perfect. He still has some talar tilt, but he's doing very well. Gone back to normal activity, working well, and doing fine. Here's another example of a post-traumatic deformity. And it's pretty clear that there's a significant malalignment. And so we decided to realign this with a dome type osteotomy, and you can see the realigned ankle joint. And I think the ankle joint function will be better with realignment. So again, I just wanted to emphasize that assessing limb alignment is an important part of assessing ankle arthritis. Now, talking about arthroscopic approaches, here's a patient with some anterior spurring and osteophyte. The ankle joint is relatively well maintained. You can see these arthroscopically. You can see the spurring on the tibia and talus. And this can be taken care of arthroscopically. Here's the images before and after debridement. Ankle joint space is well maintained. So these focal problems can be taken care of arthroscopically. Here's another form of ankle impingement that I think is under-recognized, is this can type of impingement with abnormal morphology of the talus. You can see the talus doesn't have the normal contour, and therefore I think this is going to cause problems in the long run. This was a young patient with this problem bilaterally. Here's the CAT scan showing the deformity of the talus. Here's a 3D CAT scan showing the extension of the medial column of the talus. And this is the concern. Again, I think we need more research to prove that this is what's happening with this anterior cam type impingement of the ankle leading to this type of arthritis in the ankle joint. And so I think taking care of these problems early, and so again, arthroscopically, you can remove the cam impingement. So there's better biomechanics in the joint, a more normal talar shape. And I think this may prevent, and here's that case at the time of surgery, and again, creating a more normal contour in the talar neck so that it gets rid of that cam impingement. And so I think arthroscopic approaches are useful for focal impingement, some focal arthritis, and debridement and stimulation. Now, in terms of biologic resurfacing, the most common diagnosis that we run across is osteochondral lesions of the talus. So here's a young patient, a hockey player, with a medial osteochondral talar defect. And we decided to treat this with arthroscopy, debridement, and marrow stimulation. So you can see we removed the loose piece of articular cartilage, the soft bone, going down to bleeding bone, so that you get the marrow elements filling in the area and allowing healing. Now, sometimes you have much bigger defects and you need more of an exposure. So here's a medial malleolar osteotomy. You can see the screws fixing the osteotomy, and we treated this with resurfacing using osteochondral plugs from the knee. So here's the knee incision, taking a couple plugs, and here's the medial incision, and function of the ankle following that, and here's the knee incision. So with small chondral defects, you can use autograft cartilage from the knee to resurface the ankle joint. And there's lots of literature on this, that in certain indications, it's a good way to treat these small osteochondral defects of the knee. Now, if you have larger defects, it's obviously more difficult to take autograft. So you can use allograft. So this is an allograft talus, and you can see there's much more cartilage available to restore the surface contour, and it gives you a lot of flexibility surgically to replace a small part or a large part of the joint. Here's an example of another patient with a larger medial osteochondral defect, and here's the allograft talus, and here's the piece of talus that we removed from the allograft, and restoring the shoulder, as you can see here, with a medial malleolar osteotomy. And here you can the restored medial shoulder dome, and the osteochondral in the medial malleolar osteotomy has been fixed with 2 screws and healing well. Here's an MRI done several months after surgery, showing the bony healing of the allograft and the restoration of the articular surface. Now, if it's a much larger area of involvement, this was a lady that had partial AVN of the talus, and we were going to resurface the part of the talus that was, you see here, is collapsed, but we ended up removing a significant portion of the talus, and we replaced the talar body with a allograft talus, and she ended up doing very well. This patient is actually now 12 years out from this surgery, and the allograft is still working well. So the medial malleolar osteotomy and the talar allograft. There are other options for cartilage resurfacing that I think we need more research on. So autologous chondrocyte implantation, or MACI or MACT are options. Again, there's a lot of case series in the literature, and we don't know which technique is more superior than other techniques. Here's a case of mine where we did a medial lesion, and we used de novo cartilage fragments to resurface the area. So there's a lot of interest in orthobiologics and orthobiologic adjuncts to resurfacing, the use of stem cells and bone marrow aspirate, PRP, and using, basically biologic resurfacing techniques to restore these small lesions of cartilage loss in the joint. However, when you look at the literature, again, this is a little bit old. This is a Cochrane review looking at the various techniques for cartilage resurfacing that we really don't have sufficient evidence from randomized trials. And that, most of these are level 4 case series, and that we do need more research to figure out which is the best way to treat these early arthritic and early partial cartilage loss lesions of the ankle joint. Now, I did want to just speak briefly on ankle distraction for more diffuse arthritis, and this is something that I've been interested in. And again, I wanted to thank Charlie Saltzman, who helped organize this symposium, but I worked with Charlie at the University of Iowa, and we were interested in using distraction as a means of treating more diffuse arthritis in young patients. And this was a NIH-funded study initially that we received, and these are the co-investigators in the study. And this is one of my patients. You can see has more diffuse arthritis, very young, very active, had a number of previous surgeries for realignment, ankle instability, and chronic instability of the ankle. And we ended up doing Alizaroff distraction. And you can see here the x-rays and the restoration of the ankle joint at 18 months. And here's at 4 years post-distraction, still doing relatively well. But you can see there's a reoccurrence of the osteophytes anteriorly, which were removed at the time of the initial surgery. And so these patients did well initially. And again, I don't want to take up everybody's time for a long period of time. But then we followed up these patients at a subsequent study that was published in JBJS. We looked up 22 of 27, sorry, this is a study from, this is a study from Van Roerman in the Netherlands, basically doing the same type of study, distraction, showing that a significant number of patients benefited from distraction, and only a third of the patients had failed by 7 years. We followed up our patients initially at 2 years. You can see here the 2-year follow-up, and these patients were doing well at 2 years, and we compared motion with distraction and no motion with distraction, and both groups of patients did well. The patients with motion did a little bit better than the patients with no motion, you can see here. So again, the patients with both groups of patients improved, that the patients that had motion improved more than the patients that did not have motion. Then this is what I was referring to. We did a longer term follow-up of these patients, a minimum 5-year follow-up of 29 patients, which was really 81% of the cohort. And 16 of the 29 patients still had their ankle joints working, while 13 of the 29 went on to either arthrodesis or arthroplasty. So you can see the results dropped off on this survivorship curve, dropped off significantly after 5 years. And so distraction, I think, was useful for a period of time. And we did not do anything else at the time of distraction. We did not add any orthobiologic adjuncts to the ankle joint. And so when you look at these patients, you can see that there was a spectrum of severity at longer term follow-up. These are 3 patients at 6.7 years, 7.4 years, 9.3 years. You can see there's a spectrum of severity of degeneration of the ankle joints. So the distraction was useful, and was more useful in some patients than others, but a large percentage of patients, half the patients, went on to either arthrodesis or arthroplasty by 6 or 7 years. Here's a CAT scan follow-up. You can see by 7 years, there's more cystic change, more degenerative change of the ankle joint. So I think distraction is promising, but probably need to add some orthobiologic adjuncts at the same time. So this is the question: what's happening at the level of the ankle joint? We looked at CT scans and subchondral bone remodeling, but I think it might be useful to add, to do distraction and add some sort of joint stimulation or orthobiologic stimulation at the same time. So again, I think this treatment, we should not abandon it completely, but I think we need to look at it in a different light of what we can do to make it more long lasting going forward. And so again, in terms of joint distraction, I think we need to optimize it, need to add some additional joint repair stimulation, and probably develop some ways to do less invasive distraction. So this was a lot of work for patients to have this on and have the fixator removed and the rehabilitation after the fixator came off. So a lot of work for the patient, for the surgeon. So it's not as popular as some of the other methods of treatment of ankle arthritis. So I tried to provide a kind of an overview of some of the techniques that we use for early ankle arthritis, focal ankle arthritis, focal chondral defects, and maybe some methods of treating ankle arthritis short of arthrodesis and arthroplasty. I think it's still a very challenging problem. I think that there's going to be some better things coming in the future, but we definitely need more work, more research, and we do still have a long way to go to figure out the best way to treat ankle arthritis. Thanks for your attention.